Pulmonary embolism, PE. Pulmonary embolism is a medical emergency. Pulmonary embolism is a blockage in the pulmonary arteries. Pulmonary arteries is a blockage in blood vessels in the lungs, blocking blood flow and in part of the lungs. Pulmonary embolism is a perfusion problem, not airway. So O2 will enter the lungs, but blood cannot reach the alveoli, which is the tiny air sacs, to pick it up, resulting in hypoxemia, which is low oxygen in blood, which has created a dead space. A dead space is air is present, but blood flow is absent. Thrombose formation is a stationary blood clot. So the most common thrombosis formation is DVT in the legs. Now, embolization. Embolization is a clot that breaks loose and is on the move, which is called an embolus. Embolus travels through the vein, heart, and lungs. Embolus travels and lodges somewhere and blocks blood flow. Pulmonary obstruction is a blood clot, a pulmonary artery in lungs, no blood flow past the blockage, possible right heart strain. Pulmonary embolism is sudden, a sudden perfusion failure. Virchow's triad is why clot forms. There is only 3 causes of Virchow's triad in pulmonary embolism. One is venous stasis, which is slow blood flow, and slow blood flow comes from immobility, post-op, AFib, blood pooling, obesity, pregnancy. The second cause is endothelial injury, which is vessel damage, causes from trauma, surgery, IV insertion, hypertension. Then lastly, you have hypercoagulability, which is sticky blood. And the risk factors of that is postpartum, surgery, sepsis, infection, estrogen, oral contraceptives, and dehydration. Those are the Virchow's triad in pulmonary embolism. Pulmonary embolism is sudden, a sudden onset. Respiratory, short of breath, sharp pinpoint chest pains. It worsens with deep breath, and it also, you'll see coughing of blood, which is hypnotism. Psychological neuro, that means anxiety, restlessness, and a sense of impending doom. The vital signs will be tachycardia, tachypnea, low SpO2, hypotension. The diagnostic gold standard to confirm pulmonary embolism is a CT angiography, which is an image of the blood vessels using contrast dyes. This confirms clot in the pulmonary arteries. So diagnostics. If CT angiography is contraindicated, you will use a VQ scan. And you also see a normal chest x-ray and hypoxia. So a normal chest x-ray and hypoxia equals pulmonary embolism. Early signs of pulmonary embolism is the ABGs, which is respiratory alkalosis. A D-dimer, you can see like there's a clot somewhere, but you cannot confirm it. The only confirmation of pulmonary embolism is a CT angiography. So even though the D-dimer is elevated, you still have to do a CT angiography. Okay, so the interventions of pulmonary embolism is stabilization of the O2, oxygen, stabilization of oxygen. Then you do meds, which is pain control, anxiety meds. Then you do anticoagulation therapy. The first line of anticoagulation therapy is heparin. Heparin is a blood thinner. Heparin effectiveness is APTT therapeutic range. If heparin does not dissolve, but it does not dissolve clots. It prevents clots from getting bigger, and it prevents furthering clotting. You also use warfarin. Warfarin is a bridge with the heparin. You do it simultaneously because warfarin takes 2 to 3 days to kick in. The INR goal is 2 to 3. Then you use if it's too seriously, you use a thrombolytic, which is an alteplase and retoplase, and that's only for unstable patients that are hemodynamic, which is blood movement. And the contraindications of a thrombolytic, which is alteplase and retoplase, is active bleeding, recent trauma, hypotension, and a recent surgery. And then if that else fails, you do an embolectomy, which is a clot removal. And IVC prevents future clots from reaching lungs. And that's pretty much pulmonary embolism.